Hey everybody, this is a brief PowerPoint covering dementia, Alzheimer's, delirium, anxiety, and depression all together. So I know that when we were in lab, we talked quite a bit about differentiating dementia and delirium. Dementia is a chronic, subtle onset, typically, of a brain disease. So, for example, let me think. Well, you can have sudden onset of dementia if someone has a stroke or other vascular event that is going to prevent blood flow to the brain. The brain is going to die, or the portion that's impacted. So that is like a sudden onset cognitive deficit that is going to obviously affect that person's functioning. But typically the way we refer to dementia is it's a chronic, slow, gradual onset of cognitive functional decline. Here's some different examples of that. Alzheimer's is one, and that is, according to your textbook, the most common, and it accounts for about 25% of all dementias. And then there are several examples of non-Alzheimer's types of dementias. So vascular being the one that I was referring to, that is going to have impaired flow of blood to the brain. And neoplastic, demyelinating, that would be like if somebody has multiple sclerosis and they are having their brain, the nerves in the brain affected. Infectious, inflammatory, toxic, metabolic, and psychiatric disorders. There's actually a ton of different types of diseases that can cause a form of dementia, which eventually slowly will kill the brain. And then you have sundowning syndrome, which is when you have an older adult who typically has dementia. It's a common problem for those with dementia. And they become confused or restless or agitated after dark. Sometimes they'll have hallucinations, delusions, or paranoia. And that is especially true when you take someone with dementia out of their familiar environments. So dementia, let's see, is that basically what I just said? Pretty much. Look, there's over 100 types. I did say that. And hypoxic dementia, I feel like that is where you're just not getting enough oxygen to the brain. Vascular dementia, you have blockages, also not getting a lot of oxygen to the brain. Concussive dementia would be you have a concussion and you have a traumatic brain injury that has injured a portion of the brain, so it's not working effectively. And let's move on to this. Remember how I talked to you about there are many actually. There are many of these anagrams, I think that's what they're called, where you can take a word and help you remember what these signs and symptoms are, or what the actual, in this case, what the causes are when you see a person that presents to you with signs and symptoms of dementia. So these things that are listed here are other medical conditions that could disguise themselves as dementia, especially when they have a sudden change in mentation. So are they using drugs and alcohol? If they wear glasses, or if they have hearing aids, do they have their sensory aids with them? Or maybe they're hearing impaired, or they have a trouble seeing and they don't have any sensory aids. Do they have, especially in your older adults, do they have dehydration? If they're dehydrated, they could have electrolyte imbalances. Do they have endocrine disorders such as diabetes that could be causing them to have altered mental status? Do they have emotional disorders such as depression or anxiety? Neurological disorders? Do they have tumors or traumas, infections, arteriovascular disease? Okay, so here's some different nursing managements for dementia, which I feel like your book does a great job of outlining for you. I was looking over both the Med-Surg textbook, which has a wonderful table in the neurologic function chapter called Summary of Differences Between Dementia and Delirium. That's really good information. And I was also looking in the Taylor Fundamentals Nursing textbook before I got ready for this. And it has some great ideas. Actually, it does a great job of defining what the differences are between the diseases and then what the nursing interventions are. So when I go back and look at dementia and look at what the nursing diagnoses, or not nursing diagnoses, but what the nursing interventions are for that, the biggest thing to me is that you want to understand what their baseline mental status or cognitive function is when you're taking care of them. And then if they are impulsive or if they sundown, you want to absolutely make sure you're supporting their physical safety, because they can go into that cascade iatrogenesis, which is, they come into the hospital with an illness and then they get up, they fall, now they have a broken hip, so now they've got like 50 things wrong with them when they just had one. So we really have to do a very careful job of assessing their level of consciousness and what is their baseline function. Are they staying at their baseline? Are they slipping off into some other state that's going to put them more at risk? We want to promote individually the amount of independence that person can do and help them with their ADLs, but promote them doing it themselves as much as possible. Reducing anxiety and agitation. So how would we do that? We could provide them with a calm, quiet, maybe a little darkened atmosphere, remembering to be careful with that if they have a visual impairment or if they're agitated and impulsive. You don't want them to have a dim place to get up where they're going to now fall because it was not light enough. So you really have to individualize it to what is going on with your patient. Then improving communication, I would say not only with your patient, but also with the patient's family members or those that they are most familiar with. Provide some socialization and intimacy needs for them. A lot of our older population can have literally sensory deprivation because they have no one that comes to see them, and some of them haven't been touched in so long. Promoting adequate nutrition. So one of the big things is, a well-balanced diet, but also, are they getting enough fluids? What's their hydration status? As we age, we lose the thirst drive. So we aren't even aware that we are thirsty sometimes, and that can lead to your electrolyte imbalances and dehydration, which can also exacerbate the dementias and the deliriums. And then adequate sleep and rest is important. So we want to give them some socialization, but we also want to ensure that our patients are getting adequate sleep. If you aren't getting adequate sleep, that could be one reason you go into delirium from dementia. And then we want to promote support. Like we don't want a gap in care for our patients that have dementia when they're going from home to an acute care center, maybe to a long-term care or to a skilled nursing facility. Anytime someone is moving from one environment to the next, we want to make sure that they have some level of comfort or someone there to help them as they ease into that new environment, because it's difficult for them to sometimes adjust. And then here's a great slide that has some different things that you should never do and things you should do instead. And instead, when you're listening to the poor caregivers for the patients that have advanced dementia, they are sometimes so tired and burned out because they don't get a break. I don't know if you're looking at this list. I can't tell you how many times I've heard caregivers say to a dementia patient, well, I told you, or don't you remember, those kind of things. It's condescending. It's defeating to everyone because, of course, they do not remember. Otherwise, they would not tell you, you never told me that, or whatever. You just have to reminisce, reassure, repeat all of the things it says on the instead side. There's some great little TikToks out there. I couldn't tell you who they are, but I bet if you go out to TikTok or even to Instagram, whatever social media, you can find different people that show videos or do little messages that help people that are taking care of patients with dementia or Alzheimer's. They talk about how to get them to do things that are hard, or when you have trouble with getting them to put their coat on, or trouble getting them to come outside, or whatever you need them to do. They do all these cute little videos, and of course they don't take long to watch, so that's a good way to learn some different techniques as well. All right, so Alzheimer's disease is the 5th leading cause of death for adults over 65 currently. It affects half of those over 85 years old, and it is not a normal aging process. There are 2 types, which is early onset and then late onset. So I have a good friend whose sister she had just finished her occupational therapy training and got a job, and she all of a sudden started having major memory issues. But it did happen over the span of a year, but it took them a year to go, what is happening? She was working in a center, and they were like, her charting is, the patients are mixed up. They're not charted at all. And so it just finally came to light that she was trying to hold it together, but she had Alzheimer's, and she was in her mid-50s, I think, at that point. So about my age now. So it can happen earlier rather than later. They're saying by 2050, the number of patients the number of people, let me see, there are 5.8 million people living with Alzheimer's disease today, and this number is expected to more than double to 13.8 million by 2050. So that's a lot of people. If you like taking care of older people and you're enjoying your time taking care of patients who have memory disorders, this might not be a bad idea to get into something that's taking care of your patients with memory disorders, because it's definitely increasing. Okay. 5 A's to remember to Alzheimer's diagnoses. Anomia is you can't remember names of things. And it could just be simple things like, I don't know, flowers or scissors or dinner. Just normal words that you would use every day. You can't remember what the word is. Apraxia is not using an object correctly. So you pick up a knife instead of a fork to eat. Agnosia is you're not recognizing familiar objects, taste, sounds, other sensation. And it's out of the ordinary, like you would think, wow, that's strange, what's going on with them. Amnesia, at this point, it's like you just left to go to the store you go to every day, and you get lost on the way home. So you don't know how to get back home, and the store's a mile down the road. Aphasia is the inability to express oneself through speech. So you're having difficulty with words. And I joke around all the time and say I'm having aphasia right now. It's probably not a funny joke to people that actually do experience it. So just know that it's not a normal finding to have your cognition change with age. Well, no, I said that wrong. It is a normal finding. It does change. It just slows down a little bit where you might not recall something. But it doesn't slow down to the point where you can't remember what you did this morning, or you don't recall having a conversation about something, or you forget your family members' names. I mean, those are not your typical forgetfulness items. Let's see. Oh, using word substitutions or withdrawing from conversations because they can't comprehend or remember words and meanings. So that aphasia can be you being the person being able to speak as well as to understand. And dementia is the #1 risk factor for delirium in older adults, which makes sense. So I mentioned that because I was talking about how I did my master's level project on delirium recognition in the acute care setting, and how there were no positive delirium assessments in the hospital where I did my project over the span of 4 months. And I believe the majority of that is because instead of recognizing that the patient has delirium, they instead said they have dementia. Well, yes, they have delirium because they have dementia. So it's even more imperative that we identify the causes and reverse them so that we can get them back to their baseline cognition. So there's a lot of drugs that can cause delirium, and those are listed there. So diphenhydramine is that allergy medication that we call Benadryl. Lorazepam is a benzodiazepine. It is a anti-anxiety medication. Anything ending in PAM or LAM usually is. Famotidine, or famotidine, I don't know, I never say it right, is Pepsid, which is a acid reduction agent that we typically will use in an acute care setting to keep acid down in patients that are ill. Amitriptyline is, I think it has a couple of uses, but it's mostly an antidepressant. Overactive bladder medications, cyclobenzaprine, dicyclamine, and atropine. Those are some psych meds, those last 3, I believe. So those are all common medications that can cause delirium. Here are some links to resources for patients that may be experiencing depression. And now we'll go into that. Actually, maybe we will, maybe we won't. Let's talk about depression in your older patients. So why do you think your older patients might be experiencing depression? Think about what might be happening with them. It's maybe not unusual for them to have prolonged sadness, but if your patients do have that, you should start thinking along the lines that they are depressed because it's not a normal part of aging. And they can become depressed over the death of a spouse or losing friends they've been friends with for years. Changes in their living environment. Maybe they've had to move from their home to, even if it's independent living, they've moved from their home where they've lived for 50 years into this little apartment, or they've had to move into long-term care because they had a stroke or whatever. They've had changes, or they've had, maybe they moved in with their kids, whatever. It's loss of their independence, or their financial resources could have been affected through their retiring. It could be that they're still having to work because they're unable to retire. Could be a lot of things. And that could result in depression. And it's usually a distinct change of behavior accompanied by other specific signs and symptoms like sleep disturbances, weight loss or gain, difficulty with concentration, irritability, anger, loss of interest in one's pleasure activities, vague pains, crying, fatigue, and suicidal thoughts or preoccupation with death. And I read that. If it sounds like I did, it comes straight from the National Institute on Aging. So, older adults, about 6.3 million depression. Depression occurs in about 6.3 million older adults worldwide, secondary to ageism. That's from the World Health Organization. There is a geriatric depression scale, which is a 15-question screening tool that you can look for online, but I believe we gave it to you in this slide, and we also gave it out to you during labs, so you've now seen it a couple times. So when you do that, and use that scale in conjunction with mental health assessments by other professionals. It can facilitate a diagnosis of depression. And hopelessness rather than sadness is more often associated with suicidal intention. And depression in older adults varies in its presentation depending on the person's cultural background, stress level, and underlying medical conditions. So that's that. Now let's talk about anxiety. Here's some different ways to help with anxiety. This doesn't pertain just to people of a certain age. So these are things you can do when you're in nursing school, when you're coming in to take that exam, because I'm starting to hear more people say, I have test anxiety. I feel like I told you at the beginning of the semester, and I wasn't kidding, even though maybe people thought I was. I feel like if you didn't have some anxiety when you came into nursing, sometimes you're going to end up with it. More often than not, I would say at some point, because there's a lot to learn, there's a lot to do, and you have multiple competing priorities. So read through this. Look around you. What are 5 things you see, 4 things you touch, 3 things you can hear, 2 things you smell, and 1 thing you can taste? So that's where you ground yourself, put yourself in the present moment, right where you are. And that's supposed to help people, come back to, feel what's around you in the place you are and bring yourself out of that anxious mode. And then here is just another slide that talks more about anxiety, and it's another mindfulness or grounding exercise. Talked about depression, talked about risk for suicide, substance misuse goes along with all of that. So lonely, changes in life. You could have substance misuse if you have any of these things going on. Delirium, again, is acute. And if we do not reverse it, it can be long-term. And it can even lead to death. So read through this. I don't need to read it to you, but here's some examples of where it's common to see delirium. And then not only that, but how you can prevent it in your patients. And I'm going to try to find the list that I thought was good to go along with this slide. So delirium is an acute syndrome of brain failure that can last from hours to weeks. It has a specific cause and it resolves with treatment if you identify it. I will also say that this says specific cause, but many times it's multiple causes. And so sometimes it's a little bit difficult to identify and treat. Here's some different examples. They could be drug interactions, circulatory or metabolic problems, nutritional deficiencies, worsening illness that triggers inflammatory processes and disrupts neurotransmitters. During acute illness, older adults are particularly at risk for delirium because of their decreased cognitive reserve. Prevention is the first step to managing it. So there are 6 key risk factors, and those include cognitive impairment already present, sleep deprivation, immobility, visual or hearing impairment, and dehydration. So if you took those 6 risk factors, then you could probably come up with your own list of nursing interventions. So we're going to consistently try to keep them stimulated and check on their cognitive status. So knowing their baseline, super helpful. If you know that they are typically alert to self, they can tell you their name, their birthday, but they don't know who the president is, but they know they live in Mesa. So they might have a little bit of memory loss and they might be a bit confused, but typically they're aware enough of what's happening around them. You want to keep them there. So if all of a sudden they can't tell you that they're in Mesa and that their birthday is whatever, and they barely respond when you say their name, then you might want to start thinking delirium, especially if it's a sudden onset. Sleep deprivation can lead to that, so we promote sleep hygiene. You get them up during daytime hours. If it's not contraindicated, get them up to the chair for meals. Take them down the hall and have them participate in, a crafting activity or play in bingo. Then they might need a nap. Fine, they take a nap. But we want them to be active during the day so that they will sleep at night. And at night, keep the lights down and promote relaxation. So, you can just come up with your own list, but I'm doing this off the top of my head. All things that as the nurse we can plan for to help them prevent getting delirium. Then here's your delirium assessment. And I want to say that as I look at this, I'm not sure I can do all this. Have them recite the months backwards or go back 6 months. What month is it now? What was last month? What was the month before last? So, and then the PAD assessment. Pain, agitation, and delirium. Big one, I will just say again, is your patient is in the hospital. They have dementia. They're screaming, help me, help me, help me, help me. And we end up pulling the door closed. And what do people say? Oh, it's because they have dementia. Well, is it though? Because most of our patients that have dementia are older. If you go back and look at their pre-existing conditions, is there anything that they already have that might cause them pain when they're laying around in bed? And if they have any form of arthritis, which most do, I feel like most people do, they have some type of pain, then treat their pain. A simple acetaminophen might fix some of that agitation and calling out, because pain is a very common cause of delirium. And let's see. Here's some statistics about delirium. If we do not diagnose it and treat it early, it costs a fortune. And as I pointed out in lab when we discussed this, I said we miss it all the time. Hypoactive delirium is the most common type, and it is the most underdiagnosed. This is the one that they're just tired and they're not really communicating, and we chalk it up to they just don't feel good. But really and truly, they probably are almost comatose, and we're just not catching it. Okay, suicide is common in dementia patients. And so is elderly abuse. So know that those are both common. It is hard to take care of, it's hard to be a caregiver, but it is, I feel like, specifically very difficult to take care of someone who has dementia. And sometimes the person with dementia is the abuser because they've lost their ability to make informed decisions, like their brain is not functioning correctly. So if you're taking care of a patient with dementia, you want to assess what's going on in their family or whoever they define as their family. Make sure there's not some form of neglect or financial abuse or sexual abuse, emotional abuse, physical abuse, all that going on. I guess that's probably it, and that's long enough. Thanks for tuning in. If you tuned in, the first 2 people to send me an email stating that you watched this particular video with the title and your favorite color, I will bring you something cool. I don't know what yet.